Dr. John McGann. I'm from the University of California, Davis. I'm located in Sacramento, California. Today I'm going to talk to you about ultrasound and renal mass evaluation and show you some pitfalls in evaluation of renal masses. This could be titled The Good, the Bad, and somewhat of the ugly, or some of the pitfalls we may encounter for renal mass evaluation. The main thing I'm going to concentrate on today is looking at ultrasound, but also talking a little bit about CT and biopsy. I'm not going to concentrate on plain films or MRI. I'm going to show you different things in terms of different cases. So sometimes I'll pair cases, other times I'll just show a single case at a time. So I have two different cases here. A male with a CT and an ultrasound on the left side is labeled as 1, and another male on the right side with scrotal pain and this ultrasound. So if I were to ask you which of these is a mass, which of them isn't a mass, you could go, is it an RCC, is it an artifact on either side? Going back to those, is there a mass on the left side or is there an artifact? And on the right side, is that a renal cell carcinoma or is that an artifact? When we go back through this one, it's very interesting. This was presented to me by the ultrasound technologist or the sonographer who said the kidneys are normal. However, on our PAC system, I went up and I pulled up on our PAC system and noticed there was a mass seen here, and you can see here where the mass is. So it's very important when performing ultrasound always to compare to prior studies. This is a second case that is obvious when you know it, but I struggled back and forth. So we do have sometimes artifacts that look like they are masses. This is one that I knew where an artifact occurred in the left kidney, and I thought this was an artifact. Though I struggled with it, I looked back and forth, and because of this, I went ahead and decided to go and eventually do a CT because I struggled with this. This is a so-called dromedary hump. So I'm told there's either single humped or two-humped camels, so perhaps a better name for this would be an elephant hump, so there would be no confusion. But this is a normal finding. This is a potential pitfall that most people know about, which usually occurs in the left kidney. There are other normal variants, such as the parenchymal junctional defect. Is where the vessels insert, usually upper pole, right kidney is where this is seen most commonly. Certainly the renal pyramids in kidneys may appear very hypoechoic, and as the kidney forms, you can have either scars or fetal lobulations. So these lobulations do occur within kidneys, or you may have scars. These are all normal variations. Next, I'd like to show you this 62-year-old male with renal failure. So here's a non-color on the left side and a color ultrasound on the right side. One thing that has been left out here, and we'll talk about this is of the left kidney. One thing that was done, we looked at the renal vein, and if you go ahead with ultrasound, you can do a great job of looking at the renal vein with 100% sensitivity. This is a publication we had many years ago. But there are blind spots also within the kidney. One of them is in the left upper pole. So a year later, they did another ultrasound through this, and they included a different view. They included a view through the spleen, and there was a renal mass, which turned out to be an RCC. This is with color through that area. And in retrospect, if you went back and you looked at that, they didn't include color here, but in retrospect, you can see this very slow-growing tumor in retrospect. So try to look at the entire kidney, may be very difficult. Left upper pole of the kidney is a pitfall, a very difficult area to look at. So if you look at the right upper pole, very easy to see. Left upper pole is very difficult. CT is very sensitive for lesion detection, not always for characterization, unless you go ahead and do a multi-phase CT of the kidneys and look for contrast enhancement or not. The same with MRI, fairly accurate in staging. However, there are pitfalls with CT. One of the pitfalls, we may have no base CT. And what do I mean by that? When we do a scan for trauma or we do a scan for pain, we often just do a single phase CT. This is such a case in which there was a mass seen here on this single phase CT. Hounsfield units measure 92. So what are we going to do about that? What are our options? Well, we can ignore, we call it too small to characterize, or TSTC, or there may be other medical problems in which we really just don't want to concentrate on this, and there are other things to go ahead. Or you could obtain a base CT to see if it's a hemorrhagic cyst, check old studies, obtain an MRI, or in this case, they did an ultrasound 3 years previously, and here is this. This was a cyst, and there had been no change in size over this 3-year duration. So it's very important, again, to not only do things prospectively, look at them, but retrospectively look at them. Here's another case very similar in which there is no base CT. You see a mass here. It almost looks solid, but this was called a hemorrhagic cyst. So they decided they'd go ahead and do a follow-up ultrasound. On follow-up ultrasound, a pitfall they made is when you look at the scan on the left, they compared it to the rest of the perirenal fat. If you do that, you can alter things in such a way that you can make even a solid mass look very, very hypoechoic. Here, they made a mistake, and if you look here, that and that, they don't look too much different in terms of the echo texture. So the mass compared, but they still called it a complex cyst. However, the good thing they did, they followed up in 4 months. And if you look here again, it maybe looks like a cyst, but our sonographer, I asked her to put color flow on there, and this is a solid mass. And you can see here, when you go and you look at it more carefully, here's the mass. It is not a hypoechoic or even a cystic structure. It is a very solid structure here, has the same echo texture as the rest of the kidney. Now, even with CT, you may come back and do ultrasound, or in the future, color Doppler ultrasound or contrast enhanced ultrasound, even better. So here's a CT in which on base the Hounsfield units were 49. On contrast, it enhanced a little bit, sort of in that intermediate zone. So with these cases from the literature, contrast enhanced ultrasound, this is with SonoView, can easily depict, there may be a few echoes in here, but there is no enhancement at all within this mass, and this was a cyst. Contrasted this other case during the arterial and delayed phase, you know, the Hounsfield units were about equal here in the range of 60. So again, contrast enhanced ultrasound can be helpful in these cases in which we're uncertain. Remembering there are different types of renal cell carcinoma. The most common type is the clear cell type, and the chromophobe type enhances exactly the same as the clear cell or very closely, but papillary renal cells do not enhance very avidly. And in fact, from this publication, you can see how clear cell RCC enhances very avidly, but if you over here to a papillary renal cell, they do not enhance very much at all. So you could see if you had a CT where it may be confusing. But if we do contrast enhanced ultrasound, we do see that while the kidney enhances, this mass also enhances, and this is a case of papillary renal cell carcinoma. This case also illustrates the utility of ultrasound. So if you look at this, if you took Hounsfield units of the entire mass here, Hounsfield units only increased from 16 to 20 to 24. But there's two pitfalls in this case. Look at the entire lesion and use ultrasound. So when we looked at the entire lesion and we did different window settings, you see here lower CT numbers, lower Hounsfield units centrally, but the Hounsfield units on this contrast at the periphery were 54. We did color flow as well, but you can see this is a very necrotic papillary renal cell in which there is solid components around the periphery of the mass. Ultrasound was extremely helpful in this case. Now, What about ultrasound? A lot of times it's used to look at masses. Are they cystic or solid? But a lot of very small masses may be missed with ultrasound. So what I decided to do is we would look at path-proven cases of RCC. We had 91 cases of path-proven RCC in which we had ultrasound. Many of these were cases in which I performed cryoablation or RF ablation of the kidney. So I did many of these ultrasounds of the kidneys. We then analyzed these based upon a 5-point scale from echogenic, being very echogenic as renal sinus fat, to very hypoechoic. And when we looked at this, we graded 5 as very echogenic as renal sinus fat. As we can see, these should be equal to those that are very hypoechoic, almost looking cyst-like, to those that are isoechoic with the renal parenchyma. A couple different things we found. When we go ahead and split those into those are masses that are larger than 2 centimeters or less than 2 centimeters of the RCCs, we had a huge propensity of seeing lesions that were very hypoechoic, less than 2 centimeters. And in fact, this was statistically significant at p equals 0.001 value. So it was interesting to see why we had that. Here's a couple of cases. So these very echogenic masses, even at 2 centimeters, such as this, we pick up, and these can be RCCs. Remember, the overall incidence of RCC in the being very echogenic in our overall group was about 10% overall. Smaller, though, when we looked at the smaller group, it was very high, closer than 25 to 30%. The same thing here, very hypoechoic lesions were seen more commonly in the group under 2 centimeters, this group, as compared to those over 2 centimeters. So that was significant at this p-value. Here's such a case. So here's a case in which there is a renal lesion. I had looked at it on CT, then I recommended biopsy. One of the people that biopsy had said, well, no, I think it's just a cyst. So I told him, prove to me that it is a cyst, because it looks like on CT it isn't. So the mistake made here, again, they compared this lesion to the rest of the retroperitoneal fat instead of comparing it to the kidney. They went ahead, did a biopsy. This ended up to be a papillary renal cell. So some of these renal cells can be very hypoechoic. You need to look at color flow. You need to compare them to the rest of the renal parenchyma. Now, the most interesting group are those that are isoechoic. And my theory is this. When you have an isoechoic lesion, it's very small, less than 2 centimeters, you're not going to pick it up. But if you go ahead and you have a bigger and bigger lesion, you're going to see it eventually. So if they're isoechoic masses, we may not identify them on ultrasound. These would be missed cases. So I am sure there are other lesions less than 2 centimeters that we would not pick up. Let's look at an example of this. So this is a transfer scan through the inferior pole of the kidney, the right side. We see this mass. Then this is a longitudinal scan of the more superior pole. We see this cyst. We saw other cysts, but there's something here that was missed. We followed up in 1 year. Again, this mass started to grow. You can see it color, so it is a solid mass. But we looked at the cyst again, but there's something on this scan that we missed as well. So in retrospect, when you went back after we did a CT on this patient, you can see this was the RCC. This was an oncocytoma, that lesion that was hypoechoic with color flow. But this corresponded to the RCC, missed in 2011, missed again in 2012. But in retrospect, you see the bulge here. You see there is a little bit of a contour deformity. But I think many of these very small RCCs that are isoechoic to parenchyma, we do not detect. Now I'm going to go through a laundry list of different renal masses in the adult. We're going to start with this. This is AML. Again, they're very echogenic. Sometimes I think they're more echogenic, and if they're very small, less than 1 centimeter, most people will ignore these. If they're larger masses, sometimes they may be difficult to separate from RCC. So this is an AML, this is another AML, this is with CT, and there is fat in that lesion. So that's macroscopic fat, consistent with an AML. This is an unusual AML, but when you see an AML that sort of is compressed a little bit, like in this case, it is not completely rounded, this indicates this is more likely a benign rather than a malignant lesion. This indicates this is a soft rather than a hard mass. Angiomyolipomas, if they get to be greater than 4 centimeters, may bleed. Therefore, a lot of people go ahead and would embolize these masses. They're often associated with another entity, such as in this case, where the CT shows multiple renal masses, some of which contain fat within them, multiple AMLs, and this is a case of tuberous sclerosis. So these tubers occur within the kidneys as AMLs. They're often associated with cysts. They have giant cell astrocytomas that can develop within the CNS system. They have rhabdomyomas when they're born within the heart and LAM within the lungs. So there's lots of different things that occur here, but one of them are these AMLs within the kidney. All right, here's another case. Looks a little echogenic here, 26-year-old female. But if you look at this, it may be a little more wedge-shaped than most. So a longitudinal or sagittal scan, a transverse scan with color, it's a hypovascular area here. And you go down your laundry list, and this turns out to be focal pyelonephritis. So within 2 weeks, you look at the same kidney, you can go back here, see it, you see the mass, 2 weeks later, it's gone. Acute pyelo may not be seen. It may involve the entire kidney. You may have a hypoechoic or a hyperechoic area, and it may be a vascular area, avascular area as well. Here's another case in which there's a renal abscess. So by this time it's more hypoechoic. It is liquefied here. So this is the kidney without color flow. You can see the mass here with color flow. So it ends up that renal abscesses are more hypoechoic in appearance. This is the corresponding CT, and these can be treated usually if they're very small with antibiotics rather than being aspirated or drained. Here's a very complex case. So this is a longitudinal ultrasound through the left kidney, and you see centrally there's something here that has ring down, so you know that is a stone, but look at this other mass and the appearance of the kidney. It almost is as if this is the cortex, this is hypoechoic, so what is this? Well, I'm all in the line of infection, and this is Xanthogranulomatous Pyelonephritis. So it's sort of a chronic infection caused by stone disease, maybe either focal or it may be more complex than that, involve the entire kidney. We ended up putting a drain into this case, and then it ended up on this case that required a nephrectomy. Usually in middle-aged women, infecting organisms are E. coli and Proteus, and you end up having this chronic infection that literally can destroy the entire kidney. You get hydronephrosis, but in addition you get destruction of the parenchyma, and it may be segmental or it may be complete. All right, let's go on to another case. So ultrasound here, corresponding MRI, sort of more or less a ill-defined, almost isoechoic mass. We're going to ignore the hydronephrosis, but you can see the same thing here over a more T2-weighted MRI. You look here, we could do a 3-month follow-up. This turned out to be renal lymphoma. So renal lymphoma can appear as diffuse enlargement or subtle mass, as in this case. Here's another case of lymphoma. So this involved the right kidney. You can see how much enlarged this kidney is, corresponding MRI and CT. So this is diffuse involvement of the kidney by lymphoma. Here's another case of lymphoma, multiple hypodense masses seen on CT. You can identify these throughout both kidneys. So this presented as multiple masses. This is the 2-month follow-up. So lymphoma can have multiple different appearances. You can get renal enlargement, you can get renal masses. They can be multiple, or they can be single, or they can sort of blend in between, as I showed you on that other. You can have hematogenous spread, or if you get lymphoma of the nodal mass around the aorta, it can be directly into the aorta, usually a bilateral process. Let's finally talk about some cystic disease. So I'm not going to labor on the point of polycystic renal disease, but I'll talk to you about Bosniak cyst very quickly. So when you have Bosniak cyst, you can have a classification of Bosniak 2. Now this classification is really with CT. So been a lot of talk about having a Bosniak classification for ultrasound, for sort of these ultrasound equivalents where we may want to get follow-up. And then there's also talk of having a Bosniak classification for contrast-enhanced ultrasound. So it may be more sensitive ultrasound maybe than CT in picking up lesions. So these Bosniak 2 may be very, thin line, hairline septations, cystic lesions, fine calcifications, not much else at all. So if they're complex cysts or two cysts together, they may be, where you would say, well, there's a little bit something here I'm worried about, or there may be a little wall thickening or calcifications. You might want to go ahead and follow these up. These are called Bosniak 2F. These are different examples in ultrasound of Bosniak 2 lesions. Some of these, some people would follow. So here's sort of a cyst within a cyst. Another very similar case with that, septations with color flow, simple septations. Something like this you may not follow. Something where you get a little bit more color within it, or the septation may be a little thicker. You may follow these up in a year. Finally, category 3 are sort of indeterminate masses. Usually these are removed if we see these. There can be very cystic RCCs, which are very complex and very difficult to diagnose. So this is the same case. This is at different portions of the kidney, but you see this cyst with rather thick walls, would have the same appearance on ultrasound, thick walls, and just imagine it has color flow within it. So this would be more or less a Bosniak 3 case. You would end up resecting that lesion. That was resected. It was a cystic clear cell RCC. Then Bosniak 4 really, if you think about it, RCCs with necrosis. So there may be cystic areas in there, but the main thing is they're a solid mass. So if you look here in a lesion such as this, you can see it's mainly a solid mass on ultrasound with some increased color flow, but with cystic components. Here's the corresponding MR. I went ahead and I did a biopsy of this, then we did RFA to ablate this cystic clear cell. Now, here's another one that could be mistaken for a cystic clear cell. Very young male, multiple septations in this mass, well localized mass, very discrete mass here in the upper pole of the left kidney. And this was in a young male, but it has a bimodal age distribution, females greater than 40, males less, and it almost has the same characteristic appearance all the time. However, because you can't tell these from cystic RCCs, it is recommended that these multilocular cystic nephromas be removed. There are cystic, lesions that are hard to differentiate sometimes from RCCs or cystic RCCs. Therefore, they do recommend that these are removed and usually occur in this bimodal distribution in young males as well as 40-year-old females. Now, how can I tell if this lesion on the right side here is benign or malignant? And is it different from this lesion? These two lesions, they're in different patient. One of them is an oncocytoma. One is a RCC. You cannot tell these apart because of this, we go ahead, we do biopsy, and if we note that they are an RCC, we'll go ahead and we'll do RFA or other treatments such as cryotherapy. So if you look at different series have been written, it's a fairly high retrieval rate. Many people recommend cores of these, which is safe to perform, as well as FNAs is what we do. Many of them do 18 gauge cores instead of these thinner cores, also a 22 gauge, and the results are fairly good. Some reports, such as this one, showed that fine needle aspiration actually did a little bit better than cores, but most series now recommend cores. There is no tumor seeding that is seen with these that we used to be thought there would be, so it's safe to do these. You obviously have to have all your coagulation studies, etc., to make sure they're in a range where you feel safe. So you do both FNA and cores and finally get a fairly good retrieval rate with most of these. Now here's a case here in which there is a mass seen, almost looks like that dromatory hump, but it was fairly avascular. This patient had metastatic disease. A needle was placed into there, then a core biopsy was performed. It ended up that this was a poorly differentiated lung cancer to the kidney. So I've gone through this different laundry list. We've gone over different types of RCCs. We looked at focal pyelo, abscesses, talked briefly about oncocytomas, have a very similar appearance most of the time as RCCs. AMLs are very echogenic, talked about different types of cysts, and talked about Mets a little bit, lymphoma, and then some of the pitfalls that may be encountered. So in summary, we first have to be familiar with anatomical variants. So there are different anatomical variants in the kidney. I would always recommend use of color flow for renal masses, especially hypoechoic masses, and turn up your sensitivity in such a way that you could see color flow, because many times these kidneys are very deep and it's hard to identify color flow. Watch for blind spots in the kidney. Upper pole of the left kidney is a blind spot that you need to realize. Use color flow for the renal vein. It's exquisite tool for doing that, and you can see the renal vein almost 100% of the time with color flow. Not all echogenic masses are AML, so just be cognizant of that. If they're very small, probably don't need to follow them up. If they're larger in the range of 2 centimeters, you just have to rely on how echogenic they are if you go ahead and do further therapy, or you go ahead and do a CT or MR, or do you feel safe to watch them and wait 6 months or a year? Remember that there are probably a number, and in fact most of RCCs are isoechoic to renal parenchyma. As they get larger, they deform the capsule, but when they're smaller, they may be very difficult to see. Some RCCs are complex and cystic, and I went over these Bosniak classifications, but there also may be other cystic RCCs, so you have to look for any solid elements, thick septas, anything that look worrisome to you. And there's a broad differential that I've shown you from lymphoma to Mets to abscesses to RCC for renal masses. And for a number of these, renal biopsy is very, very safe. So always think of renal biopsy if you have a question. So I'd like to thank you for your time. I hope you enjoyed this presentation and just a summary of looking at different renal masses and some of the pitfalls we may encounter. Thank you very much.